This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Yep, that's it. Thank you, everyone. So today I'll be going through a background to Ryan's Rule, our state patient, family and carer escalation in Queensland public hospitals, the method, results, evaluation. Tracy will be presenting a case study and then just where we're heading. So like other systems, we have a tragic story. The little boy pictured is Ryan Saunders. He died in one of our facilities in 2007. So like others, the coroner found his death was in all likelihood preventable. And we made a commitment, Queensland Health, my former boss, to the Saunders family, that we would do something to honour Ryan, and something they agreed to was that we'd name this process Ryan's Rule. So I'll skim through this. So there was a literature review. We were very grateful to speak to the CEC and the staff in Canberra and look at their models and take on what they had done to our system. We ran a quite large focus group with clinicians and consumers. There was extensive statewide consultation. We developed a number of resources. And then when we had developed a brochure, we put that out across the state to all the facilities, and we had 116 patients or family members review that and provide feedback, and overwhelmingly that was very positive. And then we had piloting before a site would go live with Ryan's Rule. And so this was over, we're now just over 3 years since this started, so it wasn't a very quick process. So we have a brochure for the consumers, a couple of different posters, the same message, just different pictures, just so that they realise it wasn't just paediatrics, because that was some feedback we got was because it was about a little boy that it wasn't paediatric specific, and no, it's for any patient. Staff, there's education, there's a video that's about to come out soon. PowerPoint, we developed some model guidelines, information sheets with frequently asked questions and a bit of background, and then just some of the promotional stuff so sites could use that. So Ryan's Rule is a three-step process, and it's based largely on the Canberra model care. So it made a lot of sense. So the steps are that we encourage the family or the patient to speak to the nurse or doctor caring for them at the bedside. If they still are concerned at the end of that conversation, they can escalate it to the team leader. Some sites have mandated at different steps in there that they either have, the registrar called, or if it's step 2, they want the consultant in that team called so that they're aware and can come along if they wish to or can. And then if they still are concerned at that end of that process, they can ring a single number that we have in Queensland, and that's answered 24/7. So there's a customer service advisor that provides all a government response. They answer this following a scripted process via the single number, and they do a warm transfer to the facilities. So the facilities had to nominate 3 different contacts for their facility. They were all tested and had to pass before they were allowed to implement, and that way that there was always someone when they did that. So the customer service advisor will always put the patient or the family, whoever's the caller, through to the clinician or the dedicated person at the facility and do an introduction, and it's a warm transfer of the patient. Once that process has happened, the customer service advisor fills in a template. There's an email notification to our unit, but also to the facility on their nominated email addresses. So I guess it's very fortunate we have a closed system, so we know what's happening across the state. And then there's an evaluation that they complete online, and we encourage that within 3 business days from the activation. So I've been through that. So part of the thing before they went live is that the facilities had to educate at least 80% of the staff. They had to have a committee that had governance over this and procedures and all of that in place, and I've mentioned passing that. So we're quite proud of, does this have a little dot? So all of these islands up here also have Ryan's Rule in it. So we have 163 facilities across the state, so it's statewide. It's in all of the hospitals. There's just a few of the smaller outpatient clinics that haven't implemented it, and that's across all of our hospital and health services. So That was from March this year that we had entire state coverage in our public facilities. So over the period of time, so this went live in December 2013, we've had 371 calls across the facilities, and 229 of those have been evaluated. The point of contact for the facility, it ranges from the DMS, EDMS, bed manager, ICU liaison, outreach teams. Some places initiate a MET team and the DON. And actually, some of the smaller facilities, like the primary healthcare facilities, are using telehealth, so they can get an independent review via their hub and spoke models that are already in place. So this is just the evaluation form to capture some details about the call. So we've been measuring the outcome of the Ryan's Rule call. Was there a clinical intervention? They stayed on the ward. No clinical intervention. Were they transferred to ICU, retrieved, transferred to another facility or other? And I'll present that data later. We've just added some further details to capture the exact reason for the call to help delineate. So clearly they're all not going to be about clinical deterioration, but what are the other reasons why people are using this system, so the facilities can use that data to improve their system. And then this side's about evaluation. The clinical reviewer has a summary, and then there's open feedback from the caller. So this is our feedback on those evaluated calls. So overwhelmingly, people are happy with the service. So whether the caller's needs met as a person activating the system, whether patient's needs met, and sometimes it's one and the same, and then would they be comfortable to use Ryan's Rule again? So after their experience, would they be happy to? And that's quite high. And the sites get that data to improve. So the outcome of Ryan's Rule from that evaluation was there are a large percent that fall in that non-clinical intervention category, and there, I guess, your communication issues, but 23.6 had a clinical intervention, 22.7 had something defined as other, and often that's a referral to another team, multidisciplinary team review. Some people have captured things in others that you might capture, I would define as clinical intervention. But we certainly have had people transferred to another facility, transferred to a high-level ward. Even though it says 0 to ICU, that patient ended up being retrieved to a high-level facility. So certainly there is deterioration happening that the family or carer or the patient themselves are identifying. And I'll hand over to Tracy now to talk about their case study. It's just that one on the right.
Thank you. Hello, I'm going to introduce you to Mrs. H and what happened to her at our facility. She's a 90-year-old lady, came in, past medical history of all those things there, a little 9-year-old. She was actually independent when she came in her own little unit, but she also had lots of other issues. She's an ED presentation, she had a fall at home. To note, her left leg had weakness. She was feeling heart, urinary frequency, dysuria, but she denied chest pain, but she did have some short of breath over the last 2 days. So she was a complicated picture when she arrived. So this was on the Thursday. She had an x-ray of her left hip and it noted an interconteric fracture with callus formation. So they decided it was an old fracture. Not that old, it was around 3 to 4 days old. A little bit, or maybe a little bit older than that. Her admission plan at that point was for antibiotic therapy, myocardial infarction management, and orthopaedic consultation for the old left hip fracture. Okay, because she did, when she presented, her troponin was raised, so they decided that she had had an MI. To note, she was discussed on the phone by with an ortho registrar. He viewed the X-ray, because you can review the X-ray viewer off-site. You don't actually have to be there to actually see the X-rays. And he agreed that conservative measures at this point would be best for the left side. She proceeded to plod along. She was a very difficult lady in the fact that she was got a lot of pain, got very anxious, got very agitated with everything that was going on around her. But on the Sunday, she was being transferred. So during that transfer, she was turned with very great difficulty. And as she was going down during that pivot stand, she actually complained of a lot of pain and fell to the floor. The patient stated at that point she thought she'd broke her ankle. Now, the registrar saw her that was on call on that day, and he notes that he wanted an x-ray of the right femur because it noted to be significantly shorter than the left and to rule out the fracture on the right side. There then became a change of shift. All right, the ward call reviewed the x-ray. He noted in the patient's chart at that point that there was right hip displacement but no new changes since 3 days ago. No other fracture displacement, continued PRN analgesia. So at this point they were thinking there was no fracture on either side, on the right side. There's no registrar view to note here and no further clinical entries for Sunday in the patient's chart. On the Monday, there was a team ward round. The registrar, a locum consultant, and the only thing that was documented in the notes at that time was that they needed to chase up the orthopaedic review. The physio did a review, there was discharge planning, but there was no evidence of any actual hands-on clinical review. There was lots of documentation, but not actually anything written to say they'd done a physical assessment on this lady. To note, there was lots of clinical documentation about the nursing staff. 4 nurses to assist and sponge this lady in bed. She was complaining of pain and lots of resistance. Again, she was discussed with the orthopaedic team. This team at this point still hadn't been to see this lady. They still needed to review her for the left-hand side. So they wanted to do a CT to review why she couldn't weight bear at this point. Again, like I said, this was actually all done on the phone. There was no actual physical evidence that the orthopaedic team visited the unit at this point in time. Nowhere on the Monday was any reference to what had happened the day before on the Sunday. Tuesday, there was lots of documentation from the physio. They noted that there'd been a new right hip x-ray and they reported severe osteoarthritis on that side. And that was the first reference of the right-hand side written in the medical chart. The lady herself was reported to be severely anxious, reporting pain everywhere, requesting referral to, and the physio staff, requested referral to rehab due to immobility. The nursing assessment, again, complaining of pain, plus, 3 nurses to assist. Lots of good documentation. Wednesday, another physio review at 13:40, mobility limited by right knee pain. 16:30, the family had had enough of their mum actually crying out in agony, and they called the Ryan's Rule, which has been implemented by Queensland Health. The ICU, which is our team that comes to view the patients on the Ryan's Rule, actually found there was a right knee with significantly displaced and angulated fracture above the femoral prosthesis. The right hip did have advanced osteoarthritis, and the left hip was known to have a healing fracture. And at this point, an ortho review was again requested. And at this point, the ortho team did come and see this lady. Okay. The family were obviously very, very concerned that it's taken 3 days for actually to note that there'd been a fracture on the other side. There's lots of family discussions, there's lots of clinical disclosure between the medical and the nursing team. There was lots of pain relief. We had to give her a PCA, and on the Thursday she was seen, and she had an ORIF the following week to actually look after that fracture. Now, to note, you can see here where I've highlighted where it says X-ray pelvis. The junior doctor, when he actually saw this, that's what he got to see on our X-ray view. It said X-ray pelvis. It didn't say that there was a underneath that X-ray pelvis, they actually put all the X-rays of from pelvis to hip to knee to all the way down. And as you look at the top of this system, the first X-ray that you see is the pelvis. It's not. The doctor actually physically had to follow the X-rays along to find the right X-ray to have a look at. So the first medical officer that saw this was a very, very junior medical officer working on a Sunday afternoon. This was the actual report that we found, and as you can see on the first line, it states there is a significantly displaced and angulated fracture in the distal femoral metaphyses above the femoral prosthesis. That sentence was actually not seen by not just medical staff, but by nursing staff and by physiotherapists and everybody else that actually, when you did a review on the audit, looked at this X-ray. We know that there was all these information was actually written, but what was concerning is that the whole range of X-rays that had been done in the last 3 days were all written in one paragraph, which was a bit concerning. There's the X-ray that was actually seen. We did a big review on this, and what did we come up with? There's a failure of medical and nursing handover for weekend and home teams. There's a failure to escalate any findings to from the allied health, medical and nursing from one team to the next. The X-ray reporting and the layout and the processing was actually quite poorly done, so we've done a lot of change around those. Junior medical staff supervision out of hours and at weekends, we all know we need to work on a lot of that because our most junior staff are in the out of hours teams. And really the clinical review of the teams, there was no obvious clinical assessment and there was a lot of phone discussions. Where do we go from there? Well, I'll hand you all back over to Lynn. Just by the way, this lady is now in a nursing home, but she's still alive and well at this present moment in time.
I'll just go through this. So I've spoken about the new categories. I think the biggest exciting thing for us is we're getting Microsoft Dynamics CRM that will help me compile the data rather than the manual process and spreadsheet I'm using at the moment, which is becoming a bit hard when we're getting 40 plus calls across the state a month. So that will send automatic reports out to the facilities, but also help with evaluation with a link in the email and reminder emails, and following up on people why the caller or the patient were dissatisfied, and the acknowledgements there. And it's not something that we've done. It's been done as a collective with everyone in all the facilities across the state. So without the staff and the consumers that we've had, we wouldn't have been able to do that, and the help from New South Wales and Canberra. Thank you.